shall we?
Let's.
Aquí parece que te están interrogando.
What's that? Hopefully it won't have too much overlap. I mean, based on what we talked about.
Good afternoon, ladies and gentlemen. Thank you very much for being with us today. My name is Duncan Wood. I am the director of the Mexico Institute here at the Woodrow Wilson Center. I am delighted that we've managed to bring together this group of people to be able to talk about questions of public health in Mexico. As many of you may know, this is a new issue for us. We have been talking about launching an initiative on this for many years. The Mexico Institute mission is to improve mutual understanding between the two countries. And in the 14-year history of the Mexico Institute, we have focused on a small number of issues of great importance, focusing on security, rule of law, economic competitiveness, energy policy, migration, and borders. And in recent years, we've begun to branch out a little bit and to take on some new issues. In particular, we've begun to look at the question of innovation, and we've put that underneath our competitiveness area of work. But the issue of public health is something that we would very much like to add to our core areas of programming here. As I say, it's an issue that we've talked about a lot, but it's also been talked about a great deal in the context of the bilateral agenda. And that is the heart of what we do here, is not only to increase understanding, but really to analyze and to provide meaningful, substantive public policy proposals. As yet, public policy has on public health collaboration between Mexico and the United States has not gained a great deal of traction. The Undersecretary and I were talking briefly before this meeting and mentioned a few areas where the two countries and Canada have been able to come together in a meaningful way. But I think that it's an area which has great promise. We would like to construct an agenda for bilateral collaboration on public health here at the Wilson Center that focuses on a number of issues. Our work on innovation that I mentioned earlier on is one of them. There are meaningful ways in which the two countries can come together to focus on innovation in the healthcare sector that can improve public health service on both sides of the border. We want to work on a multidimensional agenda that focuses on the cooperation on pandemics, and I know that the Undersecretary will talk a little bit about that. Joint efforts on in R&D and innovation, human capital requirements in the sector. We've all come up against the question of shortages of trained staff. And I know that one of the issues in that area has always been the language barrier between Mexico and the United States, bringing up well-trained nurses who actually don't speak enough English to be able to operate effectively here in the United States or in Canada. The question of healthcare databases and information access and the application of technology to those databases. And of course, what some people would see as the El Dorado of bilateral collaboration on healthcare, portability of health coverage, and the question of whether or not citizens from the United States, Canada, and Mexico can seek healthcare in the other countries and be covered by their respective health insurance schemes. We are delighted to have Undersecretary Pablo Curi here at the Wilson Center with us. He is going to give opening remarks, and then we will move on to a panel format. And at that moment, I will introduce the remaining members of the panel. But let me just say for now that Mr. Curi has been Undersecretary for Prevention and Promotion of Health at the Ministry of Health since December of 2011. He has an impressive curriculum in health issues, working in both the public sector and academia. He has a medical and a master's degree. He is, in fact, a real doctor. And let me just tell you a very quick anecdote, if you don't mind. When the H1N1 virus broke out in Mexico City, and if you remember, everybody ran to their apartments with little pieces of cloth over their mouths and hid out for days. The BBC asked for stories from Mexico City, and I wrote in, and at the bottom of my email, because I was in Mexico, it said that because I'm a PhD, I was Dr. Duncan Wood. So the BBC immediately seized on this, and they said, we've got a doctor, an English-speaking doctor in Mexico City who knows all about it. And so I was contacted by them, and I gave them this sort of, very exciting report from the streets of Mexico City. But I never told them I'm not, in fact, a real doctor. But he is a doctor. And he has his medical master's degree from the UNAM, has been a faculty member at the UNAM since 1986. Mr. Undersecretary, I know that you worked on the national response to H1N1, public health crisis in Mexico, brought out the very best in cooperative responses in North America. We're very happy that you found the time to be with us today. I look forward very much to your comments. The scene is yours, the stage is yours, and we look forward to engaging in dialogue with you after. Paulo Curi.
Well, first of all, gracias por la invitación. Thank you for the invitation. I will do it in English. I was asked to do it in English, and I'll do it in English. I'll try to do my best. It's not my native tongue, but I'll try to do it. And I prepared some slides around the health system in Mexico and the public health challenges in Mexico. It was tough to see what I was going to talk about, because we could spend like a whole day or several days talking about the public health system in Mexico and the challenges that you face in Mexico regarding these issues. But I had to decide upon having two sections of the presentation. First, a little bit about the health system in Mexico, to explain you how the health system in Mexico is working. And if you understand after I explain, I can get my PhD degree on that, because it's very difficult to explain. And then a little bit about three specific challenges that we're facing in public health in Mexico that have to do with health issues that we are really facing, which of course are not necessarily the only ones and maybe not the most important ones, but I had to select from a wide list of challenges, and that's what I'll try to do. First of all, our system is a system that is composed and is fragmented. It's not a one institutional system. It's composed of several systems or subsystems. A big one has to do with social security, and there we have the Instituto Mexicano del Seguro Social, which is the one that covers the people that work at the private sector. Then we have the ISSSTE, which covers people that work at the governmental level. And then we have other small ones that cover the armed forces, and the old company, Pemex, has its own system. And then we have the Ministry of Health, and the Ministry of Health used to cover all those that were not covered by Social Security. And I'm saying used to because now we have, and I'll show you a little bit, something that changed a little bit the way the system is constituted, which is Seguro Popular. And now basically everybody's insured. And I'll talk a little bit about that. And the way to translate this into the operational part from the standpoint of the Ministry of Health is through the services at the state level. We have 32 states, well, 31 and Ciudad de Mexico, which will soon become a state. They're in the process of coming up with their own constitution. But, and the private sector. The private sector is not large in Mexico, but it serves a specific population. Something that's important, and I wanted to use this opportunity to say, Duncan, thank you for the invitation. It was a challenge, but thank you. And I'm talking about the information. One of the things that we're looking is that we have a lot of duplication in the coverage of the institutions. There you see that even we have around 750,000 people that are covered by the three main insurance institutions. And I'm talking about insurance institutions because we have IMSS, as I said, ISSSTE, and Seguro Popular. And about 750,000 are insured or are on the list of the three. So we have a lot of expenditure that should not be there because we're spending on the three systems for the same people in the numbers that I show there, and you can see that on the slide. For example, there are more than almost 5 million people that are on Seguro Popular and on IMSS, which is a huge amount of people. And on the other hand, if you sum up the 71 million, the 57 million, and the 13 million, we have more people insured than Mexicans in the country. So there's something that's wrong there. I mean, we have a problem with good information in all the listings of the people that are supposed to be insured by each of the institutions. In fact, what IMSS does is that they say we have this number of people that have a job, And then they use a factor and multiply that, and they know that these are the family members, but that's not perfect. So we have more people in their listings, or at least in their numbers, than the ones that actually are being covered by them. So, and still we know that there are around 7 million without coverage or without proper affiliation. That's an issue that's very important in this slide. That what I'm trying to show you is that the budget has grown a lot since the Seguro Popular was in the panorama, which was in 2003-4, around that time. And as you can see, if you break the bars, you will see that basically the increase in the budget is from the health ministry, basically. Although all the institutions have grown, but the one that has grown the most is the health ministry, because of Seguro Popular. By law, that this is a constant increase till they reached the full coverage, which was around last year or something like that. And now what you will see is that the number of people that are being covered is almost stable, and you are only getting into Seguro Popular those that are from the new cohorts of newborns. So basically, those are the ones that are getting into Seguro Popular. So currently, it is assumed that everybody has been covered by any of these insurance systems, the Social Security or Seguro Popular. And something that's also interesting is that in 2000, we have 5% of the gross domestic product was invested in health, and now it's around 6.3%. We're far from the average of the OECD, but it has increased. And if you see that in absolute numbers, it has increased sixfold, the money in health from 2000 to 2014-15. What happens in the system? These are statistics from 2015. Actually, what you see there is the numbers per year, but in the last bullet, you see that we almost give 900,000 consultations per day, almost 12,000 surgical interventions per day, and basically 16,000 patients were admitted to hospitals per day. So that's a lot of work and a lot of people that are involved. But regardless of that, we are way far from where we should be in terms of the number of hospital beds that we should have according to the OECD average. And the physicians, we have the same problem, and nurses, we have the same problem. So we might as well keep them speaking Spanish, because if not, if they come here, we will have a major problem, even larger problem. But we're not where we should be, but those are the indicators. I mean, I wanted to share that actually that's where the system is at this point. But the other thing is that the demand, and we'll talk about the three levels. Third level is specialization. Second level is general hospitalization. And the first, primary healthcare, is usually the healthcare center at the community level. That's where the demand is, but the investment is completely around. So we invest a lot in where we don't have the demand, and we invest little in the demand. So a little bit is that primary care has been forgotten. It's something that is quite clear for some of the authorities at the governmental level. We forgot primary health care, and many of you were too young, but in 1978, there was a meeting in Alma-Ata, in the former USSR, and they suggested all the world to enhance and support primary health care. And actually, we forgot that, because now we're getting back to that, and once again, in the WHO and in PAHO and in all the health fora, they're saying we should stress the strengthening of primary health care. Why? Because actually, if you had a strong primary health care system, you will actually solve basically most of the problems that you have in health. You don't need to have, well, you need to have them, but the number of hospitals at the third level or the specialization is not needed to solve what the population really demands. Because usually what makes people sick are diarrheals or respiratory diseases that could be controlled at the primary health care. And when you talk about chronic non-communicable diseases, which are becoming a problem in the world, you can actually control diabetes, hypertension, dyslipidemias at the primary health care if you had enough well-trained physicians. And in general, not only physicians, but nurses and all the personnel, the health personnel. And something that happens is that politicians, specifically those at the local and at the state level, think in buildings. And what am I saying? It's much more politically attractive to build a hospital than to invest in public health or invest in prevention or in health education. So that's a reality. And I think that health policy makers should start, and they are doing so, thinking in the population and not only in living all these nice buildings. That sometimes what we're looking in Mexico is that there's a lot of infrastructure that is there, but it's not being used. So they built it, but it's not being used. So one of the things that Dr. Wood said, PhD Wood, said, was that we should think a little bit about universal coverage. And right now, there was with the coming into office of Dr. Narro just about 7 months ago, 8 months ago, he started talking about universal coverage, but with this definition. It is not privatization, not portability this time, nor institutional fusion. What it means is to clean the registry, avoiding duplication, to see who's responsible of what. Second, to promote, which is very important, a rational use and organized use of the existing and future infrastructure. What we are seeing is that we have here a hospital from IMSS, Social Security, and it's not a figurative of speech. And just across the street, you have a hospital from the Ministry of Health, and this is occupied at 110%, and this is under-occupied by 15%, and the services here and here could be complementary. So that's really happening in some places. It's costing a lot, and what they wanted to do with this approach of universal coverage is to make a good and sound use of the current infrastructure to deal with this type of problems as the ones that I just described. And of course, to develop coordinated actions for effective access to healthcare services. You know, you had an offer, for example, of a high-level diagnostic procedure in the hospital at La Paz, Baja California, from the Ministry of Health, and at the Instituto Mexicano del Seguro Social hospital at that city, you don't have it, and they send it by plane to Guadalajara, which is an hour and a half away, to do the same procedure that they could have done in 5 minutes time of ambulance driving. So this is the type of things that universalization is trying to do. I'm going to talk a little bit about Seguro Popular. It was created in 2004. In fact, it's a financing system. That's what Seguro Popular is. It's not a program. It's a financial system. It finances health. It's a non-contributory health insurance program for unprotected individuals at that time. Currently, as I said, it has grown. It has only 287 interventions. When you go into the interventions, actually, they become in thousands. It's not universal for everything, but it basically covers the basic needs. And it has a catastrophic health expenditure form for very expensive diseases. For example, cancer in childhood, in children, is covered by this fund, which was not covered, and that made a problem because our children did not survive as other children in the world for cancer. And well, I could go into many in-depth on this, but I will not do it in the sake of time, but we can do that on the questions. And of course, this is the number of millions of people that have been included in the Seguro Popular as insured people. This was by law established, and now we reach basically the top, which is around 57 million of people that are currently insured by Seguro Popular. And now, as I say, is reinsurance and the new cohorts of newborns that are being included that are not covered by Social Security that are including Seguro Popular. We have reached basically the top of the people that are going to be in Seguro Popular. There are many challenges. We have, unfortunately, we are facing a reduction for 2017, the budget, basically due to the pressure of public pensions, petroleum price fall, and the public debt, which are the ones that are absorbing most of the public budget. But we'll see, it's still on the chamber, on the House, and we will see how it comes out. The project that was sent by the Ministry of Finance has a cut of around 8 to 9% of the budget in health, which is a major challenge. We know that we have to be more efficient in the way that we expend the money. We understand that, but we think that there are some areas that could not have a decrease in health, and we'll see. We cannot anticipate. We still have to see how the House deals with it. Of course, healthcare cost increase. And today I just read in the newspaper a statement by Minister Naro, saying that with the actual devaluation that the peso has gone in the last several months, all the devices and everything that's being bought here in the US has, of course, gone up about 30%. And that's an issue because you have the same, even if we stayed with the same money of last year, we're facing a problem with the parity of the peso dollar. And many of the things that we get for the system and for the operational part of the system is bought here in the United States or abroad, so that's an issue. As I said, we have an overlap in the health people registry, and that's something that derives in an increased cost for the system. And we need to strengthen primary health care, as I mentioned, and refocus the priorities of the politicians, specifically at the local and the state level, which is something that it's very difficult and tough to do. Now I'll talk a little bit about the specific challenges, or 3 specific challenges, and what we are doing to deal with them. Of course, I know that I didn't go in depth. It would be impossible to really go in depth in 15 minutes into the system, but I tried to give an overview of what we're facing and where we are at the systemic level. Let me talk about 3 problems that I selected from a wide list. The first thing that I have to talk about is that we have a very important demographic transition in Mexico. We are aging. You can see what will happen in not so far from now, in about 30 years, how the population pyramid has really shifted a lot and will continue to shift, and we are going to be a population with people that are not as young as now. The other thing is that, and it's important to go over the first bullet, we do understand that health is a health problem, but it's not cost in health. It really, the causes of the health problems are outside, so many of them are outside of the health system. And this is called the social determinants of health. And they deal with education, working opportunities, the economy of the country, many things that go around households, many things that are not in health, but at the end of the day have an impact in health. And these are the social determinants of health. And it's something that should be in all the health policies. And we have tried to do that. And I'll show you an example that we're trying to do in terms of incorporating this. And we were talking a little bit about, for example, why is it that our children are not doing more physical activity? Because they have no safe places to do so. Of course, there's a lifestyle change, yes there is, but we haven't provided safe places to do physical activity and things like that, and those are social determinants of health. And there's the burden of disease in Mexico has shifted, and you can see in the slide from 1990 to 2013 that, for example, diabetes as burden of disease has become #1 cause, and you see that non-communicable diseases, ischemic heart disease is #2, and something that is worrisome is that chronic kidney disease has moved from way down the list to way up the list. And there's a puzzle in Mexico. We don't really understand, because they try to attribute this to diabetes. Diabetes causes chronic disease of the kidney, but the increase in diabetes is not perfectly correlated with the increase of chronic disease in kidney. So there's something else, and we have asked the people that do research in Mexico to go and see what's going on, because it's not only diabetes what's causing this shift. And you see other diseases there, but I just want to show that there's a change. And this is how we get sick and how we die in Mexico. Actually, as you can see, we get sick of acute respiratory infections, and then intestinal infections and urinary tract infections. And again, if you had a robust primary healthcare system, you could deal with them. These are easy to deal, I put it in quotes, easy to deal diseases. But you could do that at the primary healthcare system. And the way we die is completely different. We die of heart disease, diabetes, malignant tumors, and others. And we just, in the process, it has been accepted in the New England Journal of Medicine, a paper that talks about the attributable proportion of deaths due to diabetes in Mexico, which is what the percentage of deaths that you would avoid if you disappear diabetes from the panorama, and it's around 34%. So it means that from these 600 and more thousand deaths, about 200,000 are either directly from diabetes, 94,000 here registered, but there's a double of that that are related to diabetes through other causes, renal disease, heart disease, other causes that are associated with diabetes. So that's going to be published shortly in the New England Journal of Medicine. Now, there are lots of challenges, lots of public health challenges in infectious diseases, in non-communicable diseases, in other diseases. There are other challenges, among others, as I said there, but there are many, many challenges. I'm going to talk about those that are in black. First, teen pregnancy, it's a major challenge in Mexico. It's something that it's really a problem. One out of 5 newborns in Mexico come from a teenage mother, which is inexcusable. It's a major public health challenge. Well, I would say it's one of those in which it's a public health issue, but the genesis of this is at the household, the family. So all the society is failing if you really see at teen pregnancy situation. We register, as it says here, which is inexcusable, 30 newborns from girls from 10 to 14 years of age. So it's a girl, a children having a children, which is it's really a major issue. So it's around 11,000 per year, and about, as you see, 500,000 if you take into account the age group from 10 to 19, which is the teen pregnancy group. The interesting thing is that it has not changed a lot. It's something that is not on the way up or on the way down. It has been basically stable since around the early 1990s. So there has not been an impact in the policies. So basically, we're stalled there. There's a response. Yes, there is a response. There's a national strategy for prevention of teen pregnancy. And the interesting thing of this strategy is, if you see at the left of the slide, there's a lot of people involved, which is the important thing. It's really a multi-sectoral approach. Now, is it easy to instrument that? No, it's not easy. Why it's not easy? Because of all those involved, they have other priorities. Education has other priorities, and the National Institute of Women has other priorities. But the important thing is that we have put all the stakeholders from the government at the same table with the same goal, which is for 2030, which is aligned with the Sustainable Development Goals, with the SDGs, to have 0 pregnancies in children from 10 to 14. So we are around 13 years from that, and we hope we can reach that, and to reduce in 50% the specific fecundity rate in teenagers from 15 to 19. So this is a strategy. I won't describe a lot of it, but it has interagency and intersectoral cooperation, legal aspects analysis. There are lots of, what I'm going to tell you is incredible, but there are 3 states in Mexico that in their local laws, in their state laws, when there's a rape, the crime is extinguished if the rapist marries the raper, the girl that, so it is still in the 21st century in 3 states of our country we have this type of laws.
You know, yeah, do you know?
Yes, I know which ones, but I won't say. No, it's Baja California, Sonora, and Campeche, which is incredible.
Which is interesting. I would have thought there would be other states.
No, it's incredible. Well, if I don't have here the slide. I think I have the slide, but when you see the teen pregnancy worst problem, you would think it's in the south of the country. Yeah. It's not. It's in Coahuila and in Chihuahua, in the north part.
Yeah.
Well, okay, we have to focus and reinforce the program of reproductive health, yes. Work with schools and families, something that has to be done. It's important, very important. Guarantee the universal health coverage, and of course information for teenagers is very important. And we face a lot of challenges. We face cultural challenges. There are things that are being done in some of our communities because they have been done there for centuries, not even years, for centuries. So it's normal for them to sell the children to somebody, and so we have to deal with those type of things. Now, another issue, vector-borne diseases, dengue, chikungunya, and Zika. And I cannot avoid to talk a little bit about Zika because you have to say something about it. It's in everything. But dengue, what do they have in common? They have in common that they are transmitted by the same vector, which is the mosquito Aedes aegypti. So the 3 diseases, actually, the challenge is not to deal with the diseases, it's to deal with the mosquito. Because if you disappear the mosquito, you won't have any of the 3 diseases. So that's something that I will talk a little bit more about it when I talk about vaccines. But dengue, we have 30,000 cases per year, more or less than around 10 deaths per year, which is very low. In fact, we are very good in treating dengue cases. And chikungunya, we don't actually understand why is it that in 2016 we only have around 500 cases when last year we had more than 12,000 cases. We have an hypothesis, which is that there's interference between dengue, chikungunya, and Zika, and that there's something that is not being properly studied, but we're doing the same surveillance, we're doing the same thing, so there's not a bias in terms of, you changed the system. No, we didn't change anything, we're doing exactly the same thing. And Zika, we have only 3,000 cases, confirmed cases, which doesn't mean that there are all the cases, because there's a way to, I'm going to talk a little bit about that, but that's the trend. The important thing here is that we have a decrease, and for the first time in history, we had 3 years of decrease in dengue, and 33% decrease in dengue cases from 2015 to 2016, which is maybe something that shows that we're doing the proper things in terms of field. And the other thing is that there's a challenge. There's the symptoms, and as you can see, basically they are the same for all the three diseases. So differential diagnosis is very difficult, not only clinically but also serologically. Why? Because the dengue virus and the Zika virus are from the same family of virus, which is a flavivirus, regardless of that. And immunologically, it's not, at this point, you cannot know if somebody comes positive on a test, a serological test, if it was dengue or if it was Zika. So actually, it's very tough to say which is which. A single measure, as I mentioned here, is not enough. We have to continue with strong prevention and control programs before the introduction of a vaccine. We have a lot of pressure from the producers of the dengue vaccine, but the problem is that it came in at a wrong time, because if we didn't have chikungunya or Zika, there's no doubt that we should invest in the vaccine. But now having chikungunya and Zika with the same vector as a transmitter, you have to think a little where you're going to put the money. No? So it requires assertive actions and communication and many things to do before that. And we have a recommendation. Yes, we do have a recommendation. The SAGE is the specialized committee from WHO, and we are aligned with those recommendations for the introduction of the vaccine. But we also need to consider the financial capacity, and with the cuts in the budget and with the problems that we're facing, this problem is not an option. Overweight, obesity, and diabetes in Mexico, I would say the major public health problem that we're facing. You can understand that in a country where you have 70% of your adults either with overweight and obesity, it's a public health problem. And when you have 3 out of 10 of your children of 19 years or less with obesity or overweight, it's a public health problem. When they ask us, you are the first in the rank, regardless of that. If we were 195 of the 200 countries with this prevalence of obesity, it's a major, major, major challenge. And the problem here is the costs. Those are the costs, direct and indirect costs of overweight and obesity. This was done by the Unit of Economic Analysis of the Ministry of Health. And you can see that figure. We estimated that at 20 pesos per dollar, that's the number of millions that it costs from direct and indirect costs. And the problem is that the projections is that it's going to cost more and more and more and more and more, because we're aging, because people are not dying young because of communicable diseases, so they become old and they are more at risk of developing this type of diseases. So, and we have a national strategy. It was launched in 2013. I can tell you that after at least 2 administrations, it was the first launch of a health program by the president of the country. The interesting thing is that the 4 speakers at the launching of this, I'm going to tell you who they were. The president of the National Academy of Medicine, representing the academic sector, of course. The president of Coca-Cola, representing the private sector, endorsing that something had to be done against it, including taxes, and I'm going to talk about the tax because it's something that everyone wants to know. And the civil society, represented by an organization that's called Queremos Mexicanos Activos, which means we want active Mexicans. So it's interesting, but it was the president and those 3 that were endorsing the strategy. and that's the objective. The important thing is how we built the strategy conceptually. We have 3 pillars: a public health pillar, in which we have, as you see there, epidemiologic surveillance, health promotion and prevention; a medical care pillar, which includes quality and effective treatment and access; and the health and regulation and fiscal policy, front labeling, publicity, and fiscal measures. And the interesting thing is that we have guiding principles. I'm not going to go through all of them, but they start from evidence-based decision-making to accountability. And what we want to get is to, as it said here, increase public awareness, which I think we have done with our media campaigns and social marketing, to strengthen the primary healthcare system in response to do that, and to slow down the increase of prevalence of obesity and non-communicable diseases. And that's a very realistic objective. We're not saying that we were going to decrease 20% or 50%. It's just slow down the increase, because that's what can be done in an administration. You cannot do more. If you say that you're going to do more, it's just demagogia. Yes, demagogy. Yes, you cannot do more, because these diseases take a long time to be there. It took us about 20 years or 30 years to be where we are. It's not going to be solved in 1 year or 2 years. You have to put the foundations and to work consistently. And one thing that is very important: health in all policies and social determinants of health down there. And we had not only Coca-Cola or the private sector, we had other constituents and stakeholders working in the strategy. A little bit of what we've done: mass communication and social marketing. There is a campaign still: check yourself, limit yourself, and move yourself. It was evaluated, and you can see there the numbers. I will not go over those, but it was a good campaign. It's a good campaign still in the media. Something that it's being watched not only in Mexico but elsewhere is that there is an observatory of non-communicable diseases, which is not a governmental dependent observatory. Actually, it's administered by the Universidad Autónoma de Nuevo León, at Monterrey. And you can go over there and at that website and see what's going on the indicators. In medical care, we have a system which we didn't have before, which is an information system on chronic diseases. We actually didn't know what was going on. Now we know how many people go to consultation. We know how many of them have diabetes, how many of them are being screened properly, how many of them are under control for hypertension, diabetes, obesity, and dyslipidemia. It's online, and you can see that on the observatory. And we have public and regulatory advances. I'm almost there. We had an amendment of the Constitution, which whereby foods and drinks that do not contribute to the health of students are prohibited or are banned from schools. We also changed some schools from the general law of education, physical infrastructure, and which says that we have to have water drinking fountains in all elementary schools. We have updated the national guidelines for sale and distribution of food and drinks in school. Now, it looks very nice, right? The problem is to make it work in the field, and that's a challenge. And that's where we are, because it's not just change it and on the next day everything's going to work. No, it doesn't work like that. You have to work a lot, you have to train people, you have to convince people, you have to work with parents, you have to work with children, you have to work with everybody to start moving. But I think we are on the right track. There was an amendment to the regulation sanitary control of products and services published in the official gazette on the St. Valentine's Day of 2014. Mandatory front of package labeling, nutritional quality seal, and restrictions on advertising. And we can talk a little bit more of those, but we have a decrease of about 27% in advertisement. Of those that have requested the nutritional quality seal, around 800 and only 126 have been granted. There had been denied 358, which means they don't comply with the proper nutritional requirements. And under review, almost 300. This is something that everybody wants to know a little bit, is the tax. The tax is 1 peso per liter in flavored and sugar sweetened beverages, and about 8% in all those foods, which could be put into the concept of junk food, but it's more than that. As you can see there, it's different. But the important thing, does that have an impact? Yes, it has. Well, Mexico had the largest per capita intake of soft drinks in 2011. And after 1 year of the implementation of the tax, there was a reduction in purchases of tax beverages of an average of 6%. It depends on the decile of income, because in the lowest deciles of income, it was 12%. In the highest deciles of income, it was less than 6%. But there we also saw an increase of plain water of 4%, and this is published in the British Medical Journal. We are, in the next steps, we have to evaluate what's going on. So we are currently, as we speak, we are in the field with what we call the National Household Survey, Midterm National Household Survey, which is being conducted in more than 11,000 households, and we are asking on these issues that I told you, and others, of course, but we're asking people at the household if they know the labeling, many things of the ones that I said, and we'll see what the results are. Well, there are enormous challenges. Yes, overlapped registry, budgetary constraints, fragmented health system, insufficient human resources, specific challenges, as I mentioned. We need to strengthen primary healthcare, reinforce successful strategies, because we know there are successful strategies, and of course, reevaluate the strategies in challenging topics as the ones that I mentioned. So I just want to acknowledge all these people and these institutions from the Ministry of Health that gave us the information, and people from the staff that helped me put together this presentation. Thank you.
I think you complied perfectly with the time. That's extraordinary. Thank you so much, Mr. Undersecretary. A terrific panorama of the Mexican healthcare system. Thank you for explaining at the beginning how the system actually is structured. It helps a great deal in structuring our conversations afterwards. I'd like to move on to our panel discussion. And I want this to be a dialogue as much as possible. And so I know that there is complementarity between the presentations that we have here. We'd like to move through the presentations, and then I'd like to invite our audience to engage in conversation with the speakers, including Undersecretary Khoury. Before we actually move into that, I'd like to mention the organizations which have sponsored our work. I'd like to recognize in particular Chris Kuzmak from Pharma. He's a board member of the Mexico Institute. Thank you for being here, Chris. I'd also like to recognize United Health, who has been very, very kind. Adrian Rothkopf from there. Amgen, of course, is a board member of ours at the Mexico Institute, and we're grateful for their support over the years as well. Let me talk about, introduce our panel now. Andrew Rudman is probably known to many of you. He has extensive experience in both public and private sectors on diverse issues, trade, international affairs, and public health. He is the managing director of Manat Global Strategies here in DC since March 2014. He is also a Wilson Center alumnus, having worked with the old Latin America program many, many years ago. Actually, not that many, sorry. I don't want to make you seem old, Andrew, but a few years ago. To his right, and who will be speaking second, is Amy Glover. She is the director of Mexico practice at McCullough. She worked for over a decade in consulting and banking in Mexico City. I believe you are a Mexican citizen as well, Amy, is that correct? Yes. And is definitely buena mexicana aquí in DC. She is the president of the DC chapter of the Asociación de Empresarios Mexicanos and a very good friend of the Mexico Institute. And to Andrew's left, Catherine Meller, a new friend of the Mexico Institute. She is the executive director of the Global Health Initiative at the U.S. Chamber of Commerce, has worked on diverse issues and areas of the world through her work with the Chamber of Commerce. Like all good Australians, she has tried to get a truly international experience. All the Australians that I've met have been people who have lived in multiple countries, and I think you continue that tradition very well. So we're going to begin with Andrew, who I know is going to make comments on the Mexican public health sector based upon a paper that he wrote and published a little while ago for Manat. Andrew.
Thank you. Here, up there?
Wherever you feel most comfortable, Andrew.
Yeah, I think this will work. If everybody can hear me. Thank you, Duncan, for the invitation to be here. It's really a pleasure to be here with all of you and to share the panel with my colleagues. And with the undersecretary. Obviously, a little bit intimidating to talk about somebody's healthcare system when someone who runs the system is at the table with you. But I don't know. I think he'd hit Amy before he hit me, so I'm probably okay. And it is a pleasure to be at the Wilson Center. It was a long time. I always say my first real job in Washington was at the Wilson Center back in the Smithsonian Castle days. Let me start. I think Undersecretary Curry did a great job describing the system, explaining what I would agree is a complicated system to understand. I think if you know the system, what he said is pretty honest, pretty sobering, not really surprising in terms of what's happening in the system and what needs to happen. And that's where I'd really start, which is I think there's a pretty broad consensus in Mexico that the healthcare system needs some changes, needs some reform and some attention in terms of improvements of efficiency, ideally more spending, et cetera. I think there was hope that there might be some of those reforms, some bigger reforms in this administration and the Peña Nieto administration. There have absolutely been some developments, but I think any larger whole-scale reform would happen in the next administration. But I think the fact, and this is what I really want to talk about today a little bit, the fact that there's a consensus that there needs to be reform, or maybe I should say change and not reform. There needs to be some changes. The budget's not there, as Undersecretary Curry pointed out, so there isn't going to be more public money, which means any demand probably has to be satisfied by the private sector, either independently or in conjunction through public-private partnerships, PPPs or P3s, however you want to describe them. And I think, in fact, that's a great opportunity, and there are lots of opportunities for collaboration. So let me try to identify some of those in just a couple minutes. I think the first place you're going to see more demand for public-private partnerships is from the public sector, recognizing that they're not able to deliver services as efficiently or completely as they would like. They need to find ways to stretch the budgets that they have, and this already takes place. One thing I think it's maybe worth pointing out is that the public institutions, particularly IMSS and ISSSTE, the two Social Security institutions, do more than just health care. They do pensions, they do travel services, child care, grocery stores, a huge range of services. And I think it's something that perhaps a future administration might think about splitting off, because inherently, when you have an institution with multiple responsibilities, demands for one thing may cause reductions in spending in another, right? I mean, you're not going to tell people you're not going to fund their pensions. So what are they doing? Well, one thing the institutions do is rely on integrated services, on hiring private sector entities to provide services that the public sector would normally provide. Best example probably is dialysis, which IMSS, Social Security, uses or outsources or uses integrated services pretty extensively because the private sector can provide the service less expensively than the public sector. There are some challenges with that. You want to be sure, and there needs to be a regulatory framework that ensures that those people providing the services aren't cutting costs to a point that jeopardizes the health of patients. You hear stories, I suspect anecdotal, about things being reused that shouldn't be reused and lower quality products. And obviously you don't want that. But I think the pressure to find ways to provide the services, particularly dialysis, which is so critical in kidney care and diabetes care, will continue. And I think not only can it be in things like diabetes, but I think it's likely to expand. You may see more outsourcing or integrated services in primary care, in surgical procedures, and in rehabilitation services. So I think what you're going to see is something more like what we have in the States, where things we used to go to hospitals for, we now go to office buildings downtown. And you go in and you have the procedure and you go home the same day, and it looks like you just went to work. And I think you're going to see more of that in Mexico. From the private sector side, I think increasingly the private sector is going to demand systemic reform and alternative forms of treatment, because the private sector already knows, all of you in the private sector know, that healthcare, there's a direct relationship between healthcare and productivity. Workers who are not there because they're homesick, or workers who are at work but not performing very well because they don't feel well, aren't as productive, right? We all have our days when we don't feel that well and we know we don't get as much done. And you magnify that by whole economy, it's pretty clear there's an impact. And I know Catherine's going to talk about that. We did a study that's going to be released next week in Mexico looking at the impact of healthcare and on productivity in the automotive sector in Guanajuato. So one sector, one state. And you do see the correlation that I described and that all of you would have expected. So I think what's going to happen then is employers and prospective investors are going to take those things into account. They're going to think about, if I go into a given state or city or country, am I going to be able to provide the kind of health care I need for my workers? And those states that have more limited access, where people wait longer to get access to doctors or have to travel further to get doctors or have shortages in pharmacies, are going to be at a comparative or competitive disadvantage over states where healthcare is provided more efficiently and more broadly. And that is going to potentially apply on the federal level as well, that if Mexico wants to remain competitive, it's going to need to find ways to address those types of issues that increasingly employers care about. So what will happen? I think in the private sector, you're going to see employers, and you already are seeing employers basically providing their own care, having either their own primary care facilities on premises because they realize that that's more efficient and cost effective than having their workers go to EAMS and wait a long time. I should say that there was just actually an article in Reforma earlier this week talking about exactly this issue of how long do people wait for care at IMSS or Social Security, and the impact that has. Mikel Ariola, who's now the Director General at IMSS, talked about how he has dedicated himself to making improvements. So again, it's not that nobody knows about these issues or there's disagreement on what needs to be done. I think it's more a question of pace. So companies are going to look for ways to provide their own health care. And as I said, one way is going to be to do it in-house in a large factory setting. And that provides opportunities, I think, for innovation and investment. One sort of perverse advantage, if you will, Mexicans are used to paying a lot of their healthcare costs out of pocket. Mexico is one of the highest rates at around 45%. So the reason I think it's a perverse incentive is if Mexicans are used to paying out of pocket for healthcare, they are likely to be willing to pay out of pocket for better healthcare. So I think you have an advantage. It isn't the case of, imagine a system where suddenly people had to pay for things they didn't have to pay for. And I think the next step to that is insurance. I think there is a market and will be a market for secondary healthcare insurance, supplemental healthcare insurance in Mexico. Employers already provide it to some extent, although not perhaps as much as they would like. Obviously, there are cost implications, and there were changes in the 2013 fiscal reform regarding what you can deduct in terms of employee benefits, and so that's a disincentive to providing healthcare insurance. But there are companies that provide it for the reasons I mentioned. I think the other opportunity is for insurance companies to go directly to employees, to the private sector, for people who, again, recognize, gee, I'd like to go to the private sector. What can be done to minimize the cost of that treatment? And I think one sort of side note to that is that in the Mexican healthcare system, most doctors practice in both the public and private sectors, sort of a morning at the public sector, afternoon in the private sector, which means you're seeing the same doctor in either system. They have the same knowledge, they have the same training. One of the challenges is that if you have to depend on the public system, the doctor is limited on how he or she can treat you and what he or she can prescribe. So there is a difference between the systems, even though you're seeing exactly the same doctors with the same very good training, by the way. And I think the last major possibility specifically within the healthcare system refers more to the manufacturers, to the pharmaceutical and device manufacturers. Because of the increasing pressure on the public healthcare budgets in order to sell into the market, without a doubt, companies are going to have to find ways to be a little more creative and a little more innovative. And that, for example, may mean using more risk-sharing schemes, which can be structured in many different ways. And I know, and many of you know, that the public institutions are already exploring that and are open to that. And I think you just need to look more. There's just really quickly, I think there's a couple other areas that are tangential to specifically the public healthcare system, but where there's private sector opportunity that will, in the long run, help improve the quality of the Mexican healthcare system. One is in clinical trials. Mexico is a great location to conduct trials. You have a very highly skilled, highly educated system that can manage those trials. You have CROs, you have research institutions, hospitals, universities that are fully capable of conducting the trials. The costs are much lower than in the United States. The demographics and the comparison of the demographics between Mexico and the U.S. are such that you can use Mexico in a multi-center trial and use that data in the U.S. Or Europe. The Mexican government has taken many steps to accelerate the approval process. They are aware of the benefits, and that's always a challenge, is do people really understand that clinical trials are an economic benefit as well as public health benefit? Mexico understands that and is taking steps. They have changed the regulations and updated the framework to make sure the standards are high, and I think that's reflective of COFEPRIS's dual role of promoting economic development, but also ensuring public health and public safety. Following off of clinical trials, research and academic partnerships, and I'm not in this case referring to the sort of partnerships you see where U.S. institutions are looking for high-paying, cash-paying patients to come up to the U.S., but rather, which is fine. I'm not criticizing that business model, but what I'm talking about is more opportunities to do collaborative projects. Whether it's research or training, it can be educational, it can be technological, it can again be sort of clinical trial and best practice sharing. There are already lots of partnerships between public and private institutions in Mexico and the U.S. The ABC Hospital in Mexico has partnerships, for example, with Houston Methodist and Texas Children's. UNAM School of Medicine has partnerships with King's College in the UK and the University of Groningen in the Netherlands, and there are lots of other examples, but there's opportunity for more. And I think one of the exciting opportunities, and Dr. Curry alluded to this, when you have a system like AIMS with 57 million or 71 million patients or beneficiaries, the wealth of data and the ability to identify the right patient population is there. It's just a question of structuring a partnership in a way that's a win-win that takes into account patient safety and really brings benefits to the Mexican institution, which in the long run improves their quality and maybe even decreases the need for wealthy Mexicans to leave the country, much to the chagrin of U.S. institutions that want them to come up here. And the last area that I'll mention, and we've done some work on this in the past at Manat Jones, is medical tourism, which we really see as a great opportunity for Mexico. You all know the proximity, you know how easy it is to get to Mexico. There are direct flights to either Cabo, Mexico City, or Cancun from 40 U.S. cities. The quality of care is very good. There are Joint Commission International Accredited Hospitals in Mexico, which have the same standards as U.S. hospitals. The costs are much lower. As I mentioned, the quality of care is equal or better. You don't see people thrown out after, an hour after a surgery so much in Mexico. And in fact, lots of Americans already go to Mexico for non-insurance covered procedures. So alluding to something Duncan mentioned, I think the opportunity for employers to offer their employees the opportunity to have treatment in Mexico is definitely there and should be considered. And I think as healthcare costs increase in the U.S., you'll see companies looking more and more, making the same sort of calculation, where can I get the service I need for a better cost? So we did a webinar on this subject earlier this year. It's still viewable online. I'd be happy to connect you to it if you're interested. Let me stop there because I don't want to monopolize time. And again, Duncan, thank you. Thank the panel for the opportunity.
Thank you, Andrew. That was fantastic. And I'd like to point out that we do actually have some copies of Andrew's paper outside on the table. It's great that you actually brought up the issue of medical devices and the cost of those, which was also mentioned by the Undersecretary. It's intriguing, of course, that many of those medical devices, or parts of those medical devices, are of course made in Mexico, then exported to the United States, and then sold back into Mexico. And there may well be opportunities there for looking at how you do that better. I'd like to move over now to Amy Glover. Amy, the microphone is yours.
Great, thank you. I want to congratulate the Mexico Institute for having this forum. This is something I think in Washington, we don't discuss health issues enough as it relates to Mexico and Latin America. And I think we've been looking for a space where we can have more productive conversations about how the private sector and the public sector can discuss these issues. And there aren't that many productive forums to do so. So I think this is a great effort. And I think one of the things that we really need to collectively highlight is the importance of health for economic competitiveness and economic growth. I think Undersecretary Curry alluded to this as well, that this is not, we're not going to be able to find solutions unless we take a more holistic approach to tackling the problem. I mean, understanding why health is such a critical indicator for economic success of a country. You know, when you look at the system in Mexico, it's tough to figure out how to tackle some of the challenges that are faced. The OECD study that was released earlier this year had a good phrase that I liked that says, the Mexican system is a set of vertical subsystems whose operations are rigidly determined by historical and institutional legacies, which I think hits the nail on the head. A lot of the reason the Mexican healthcare system is set up the way it is you have to look back to kind of the arrangements that were established after the revolution, kind of a corporativist system that was set up by type of employment. And it's just hard to understand. It's complex. There's a lot of duplication, and it is definitely an area where probably there is a pending big reform that is required, as you've seen in other sectors in Mexico, like telecommunications, energy, et cetera. United Healthcare Group just released a report about recommendations for the U.S. healthcare system. And the title, I think, is telling: a modern, high-performing, simpler healthcare system should be the goal. And simplicity sounds simple, but it's not. But you know, when we think about simplicity, thinking about the end user of that healthcare and how important it is to be thinking more about providing quality healthcare is critical. In Mexico, ostensibly, there is universal healthcare, but it's in fact still you know, the results are not there in terms of having complete coverage for Seguro Popular or having anything like and do kind of equal quality care across the different mechanisms. As Undersecretary Curi pointed out, Mexico is investing more in health than it had before, but it's still under-investing if you look at the numbers of the OECD. And public spending is about half of what it is in the OECD, so about 3.2% in the case of Mexico and 6.5% for OECD, 45% of those expenditures out of pocket. So still an area that somehow we have to make the case that it really behooves Mexico to invest in a much more substantial way in health, because it is a key motivator for economic growth, which I think other areas of the government or the economy don't necessarily recognize that, which is hard to make that political case at times. Let's see. Getting back to this issue of the holistic nature of what was mentioned, the social determinants of health, and working with the other areas of the government like education, investments in infrastructure, and a lot of the public goods that contribute to good health. If you don't have the proper infrastructure and you have massive amounts of traffic and you don't have public spaces where people can walk, you produce a whole series of health problems related to both pollution, lack of physical activity, and you know, other challenges related to the increase in non-communicable diseases that we're seeing, not just in Mexico, of course, but regionally and globally. And I did want to take on, it is interesting to look at, you know, what's happened in Mexico with the NCDs and what the response has been. Pajo talks about Mexico as really an example to follow regionally in terms of the decisions it took in taxing certain products, which of course has created a lot of nervousness by the business sector, and questions, has this tax worked? What are the implications? There's differing studies, competing studies in terms of, has consumption of soda been reduced, yes or no? In the end, certainly it's been an important source of revenue for the government, so I think companies should expect this is not going to be something that is going to be modified in the near future. The question would be, how is that money that is being, what is being done with that revenue? And I think that's where we need to place the focus and perhaps some concern in terms of earmarking those funds so that they're specifically destined towards programs towards education. One of the major projects is putting water fountains in schools, because the reason there's such a high consumption of soda is because there's not access to potable water. But the process has been a bit slow to date, but that really has to be the focus of the discussion in terms of if there is going to be this taxation, how can we properly invest that in the wisest way? Well, both the issue of diabetes and obesity is a major challenge that is creating these costs that Undersecretary Cody underlined very clearly. And it's not still, we're going to be having to look for solutions for how to attend to these problems, and really the government alone can't come up with a solution. There's going to have to be joint cooperation with the business sector as well to be able to attend to these issues. One of the results of this decision by the Mexican government related to the tax has been a modification of the product offering, which has been interesting. If you see some of the modifications, and instead of selling soda, there's been more water, more flavored water and whatnot. So I think it is important that business take a look at these issues and tries to help cooperate in modifying its offering. There's also some interesting efforts by the private sector in Mexico to help improve the health of their employees. A workplace wellness council was formed about 5 years ago. It now has about 150 members in Mexico. And a lot of them are large multinational companies, also Mexican multinationals, that work with this organization to promote healthy habits in their workforce. Everybody acknowledging that, this has to be something that is worked at as a joint project in order to reduce costs and improve productivity generally. And I was very happy that the issue of teen pregnancy is something that you highlighted. I think in Mexico and generally, the economic empowerment of women is so critical to growth and development, and women's health issues are particularly important. I think there's so much more that could be done in terms of investing in prevention of many things that just can be easily detectable if there's proper screening for cervical cancer, for mammograms, et cetera. The issue of teenage pregnancy is terribly worrisome, especially the fact that it has barely gone down at all over the last 20 years. And again, we come back to the fact that this is not just a health issue. This is also, I would say, a human rights and legal and rule of law issue. And there is a responsibility to protect young girls from abuse that I think needs to be taken much more seriously. Mexico made important strides in reducing maternal mortality rates as part of the Millennium Development Goals. And it's worth noting that the full goal was not reached, but there was a reduction from 88 deaths per 100,000 live births in 1990 to 38 in 2014, so they came to 75% of the Millennium Development Goal, which is great. Still work to be done in those particular areas. So just to conclude, so we can start the discussion, I think it's important to emphasize that there has to be a greater political priority assigned to solving these health issues, and I think part of that also has to come from civil society. Interestingly, you don't see a lot of mass protests in Mexico demanding the improvement of health services as you do in other countries like Brazil, for example. And I think, we probably don't want to suggest that, but the point being, taking more responsibility and pushing for these improvements and making the government understand that this has to be a priority, a national priority, not a priority of the Ministry of Health, but a national priority that has important implications across the board for the country. So I'll leave it at that.
Thank you, Amy Glover, rabble rouser. I like that. That's very good. And lastly, but by no means least, I'd like to turn it over to Catherine Meller. I know that Amy just mentioned the question of workplace wellness. It's an issue that you're very familiar with, Catherine. So I'm going to pass it over to you. You need the clicker.
I need the clicker.
I'm gonna pass it down for you.
Thank you. Yes, a perfect segue. Duncan, thank you very much for having me and inviting the Chamber here. I've been asked to talk about the work that the Chamber has been doing with its global initiative on health and economy. And Duncan, we're new at this as well. I think it's rising as a priority amongst business associations and groups all over the world, this important issue of health. As an organization that represents employers, demographics matter. They matter to where our companies are going to invest. And as Amy said, health is an important indicator of economic success, increasingly so. So the mission of our initiative is up there for you to read. We, with our founding members, a couple of whom are in the room, Saljeen and Eli Lilly, have gathered a group of experts and commissioned a study to create a platform of engaging governments cross-ministry in discussions about ways in which business can better support health outcomes. Our companies, the two that I mentioned, J&J, Chevron, et cetera, have had employer-led wellness programs in their companies for decades, incentive models, step challenge, financial rewards, screening events, etc. Even the most basic of those have proven to provide a return on investment to an employer. And we are challenging ourselves with this resource of knowledge amongst the companies to work with governments to help implement some of those similar practices in the public health space to encourage a greater focus on wellness and productivity. It's a global platform. We're all over the world. We are next in Mexico, excitingly, next week. We will be there with Andrew, with some companies in the room, and with the MEEF, CCE, local business partners, AmCham. And we have meetings with the Ministry of Health, but importantly, we also looked for meetings with the Ministry of Finance, the Ministry of Labor, the Ministry of Economy. To the points made by my colleagues here, and to you too, Undersecretary, this is a health in all policies approach, a whole of government response, a whole of industry interaction, and a whole of society as part of finding the solutions. One thing in common in all the programs that we have worked on is that there's no government, not the Saudis with their money or the Chinese with their ability to control the government, that can tackle the burden of increasing non-communicable disease in the adult population, which is what I'm going to focus my next few points on. I should say that health is also newly added to the topics of the U.S. Chamber's U.S.-Mexico Leadership Dialogue as well. So last year we commissioned a study. It was published this year by the Victoria Institute of Strategic Economic Studies in Victoria, Australia. We profiled 19 countries, ranging from high-income countries like the United States, developing countries like Kenya. The results were varied in the assessment of the economic cost to productivity from absenteeism, presenteeism, which Andrew mentioned, which is underperforming while you're at work, early withdrawal, and then the cost of pension drawdown. The constant among all countries, regardless of GDP, was that the cost is high and it's increasing. On average, 6.5% of GDP is lost to those indicators I just mentioned. And when we think about the return of investing in health, which is what we've all talked about, including the Undersecretary, it's productivity, but it's also adding to increasing the size of the labor force through increased survival rates. It's increasing the ratio of labor to dependents. Prosperity also creates increased school attendance, improved child health, lower fertility, etc. And Harvard University did a study last year that said that a single year's increase in life expectancy can have an increase of 4% in GDP in an economy. I won't spend time here. The Undersecretary did. I mean, there's basically three components that go into the productivity losses in our study. That is the profile of burden of disease in an economy, the demographics of age, and the access to care. I think the burden of disease in Mexico is fairly well known. As the Undersecretary said, 70% of adults, 3 in 10 children at risk of diabetes. 77% of deaths are NCD related, and you have a 16% likelihood of suffering death from an NCD before you're 70. In 30 years, this is a report that came out from the UN, there's been no country yet able to reduce obesity in their market. So as we look at these burdens of disease, it's really important that we think about prevention as the king of cures, or the best case scenario. But when you are dealing with a population already overwhelmingly sick and at risk of being sick, it is detection and treatment and management of treatment that is the most urgent priority in front of us in the United States, and certainly in Mexico as well. With age, in Mexico, and the Undersecretary talked about this, it's a young country. It's a tremendous economic asset to have. The average age of the population in Mexico is 28. In the United States, it's 39. In Japan, it's 47. In some of your regional countries, Colombia, it's 29, Chile, 34, Brazil, older than that. So having a young population is an asset. But what this figure here this graph here doesn't quite show well enough is the acceleration in age in Mexico, which of all the countries that we profiled, with the exception of Saudi Arabia, is accelerating the fastest. So I was talking to the author of the study last night in Australia, and he described the population wave in Mexico as a slow-moving tsunami for the healthcare system. Aged care is part of it, but again, the burden on the workforce, the ratio of employee to dependent, is where this study is really creating a call to action. So the outcomes, this is the unique piece of data that our study, and I have copies of this here with me today. This is the unique piece of data that the study has produced, which Bruce and the University of Victoria have been doing work in APEC and work for the UN as well. And this is this cost in GDP. For Mexico in 2015, it was 5.7% GDP. By 2030, it will be 6.5%. That's the combination of presenteeism, absenteeism, early withdrawal, and pension drawdown. It's lower as the comparator countries there, certainly lower than the United States, but given the demographic modeling on age, the expectation is that it will quickly and rapidly increase. The key takeaways of our study and the focus of the work that we're doing with this platform is to really talk to governments about ways in which our members, the the expertise, the resources that they have, the desire that they have to engage more in improving health outcomes can be better utilized with the Ministry of Health, with the Ministry of Economy, and others. We have a program when we'll be in Mexico next week that will talk about possible partnerships on prevention and treatment, screening programs that employers can use that can be scalable to small employers, not just large employers. Organizational innovation is a core pillar of recommendations that we make to the government, and that has been highlighted also. The health in all policies concept that there in many governments around the world is a coordinating body of health that meets horizontally across ministries to make sure there is consistency in the development of policies that matter. For example, building a public park to encourage outdoor activity. Innovative financing schemes, and the importance of health infrastructure and the focus on primary care. That is what we'll be discussing in depth next week. I have brought copies of this study. It is available for all of you. Duncan, we're not a member of the Wilson Center, I don't think, but I support your idea of taking up health as a topic and look forward to working with you more on these issues.
Thank you, Catherine, and the Chamber is a very good friend and partner to the work that we do. So thank you so much for being here, for sharing your data with us. We have about 30 minutes left in which we can engage in dialogue, and so I have a series of questions that I'd like to pose to the panel. But what I'd also like to do is I'd like to intersperse those with questions from the audience. And so if anybody has questions right now, please raise your hand. It is traditional for us to ask you to present yourself and your affiliation, so we know exactly where the question is coming from. So please do. The microphone will be coming to you right now, sir.
Thank you. Good afternoon. My name is Andy Carey. I'm here from the U.S.-Mexico Border Philanthropy Partnership in San Diego, California. Duncan, it's always good to see you, and congratulations on yet another amazing panel. Mike, I don't necessarily have a question, but I have a comment. Dr. Khoury, I am fascinated with your presentation, and I thank you for your honesty and the transparency with which you presented the information. I've been utilizing social media during your presentation with all our friends in Mexico, telling them about what I'm hearing from you. One of the challenges you put before us was the importance of public-private partnerships, and I would like to suggest that there's another P that is missing, and it is philanthropic partnerships. There is a great need in Mexico for the philanthropic sector to support the growing needs of the healthcare sector. And there is a lot of good, positive work happening, but it is diminishing, unfortunately, primarily in the border region from Tijuana to Matamoros. The funds that are coming into health centers, health shelters, centers for women and girls primarily, is diminishing. And I wanted to know, on behalf of the government of Mexico, what efforts you might be able to put forth to encourage philanthropic foundations to continue to support where the government is having to make adjustments.
Thank you, Andy. Any more questions right now? Please, Chris. Put it in, and then I'll provide a couple of things as well.
Great. Thanks, Duncan. And rarely do I need a microphone, but I'll go ahead and use one. Thank you all for your comments. I think they were all very enlightening. And Mr. Undersecretary, thank you for your very candid and honest presentation. I think it's rare that we see a presentation on the Mexican health system, yet alone any health system globally, perhaps including our own here in the United States, that is as candid as the one you just presented. So very much appreciate that. One of the things that we, and I apologize, maybe I'll one step back, Chris Kuzmuk from Pharma, and we represent the innovative biopharmaceutical industry here in Washington, but also globally. But one of the things that I think Catherine, Andrew, and Amy all touched on, either directly or indirectly, was coming back to the need to make health a priority for Mexico, not just to the government, but also in civil society. And the more we work in Mexico with our colleagues on the ground, the more we hear that it's simply not. And I think that's reflected in expenditure from the government side. I think that's reflected in kind of, I think what Amy alluded to earlier in terms of the public sentiment, whether that's intense or lack thereof. And so I guess my question is kind of general in terms of what can we do to work with you and your colleagues to help raise health up that prioritization list. You know, it's so important to invest in health, and conversely, the negatives of not investing in health properly have detrimental impact. So it's something that we're very interested in, very concerned about. I think a lot of the comments, like I said, go to that, and so be interested in your thoughts on how we make it more of a priority across the board.
Thank you, Chris. Yeah, we can take a third question here. Jimena?
Hi, my name is Jimena. I'm an intern at the Mexico Institute. I have a question for Dr. Curi, because I'm very interested in the intersection of vector-borne diseases and now rapid urbanization. And the rapid urbanization that the Latin American region as a whole, and Mexico is not like an exception of this, and how that's going to create a jump for vector-borne diseases and also other neglected tropical diseases. And I was wondering if you could speak about the efforts that are being done. I know, for instance, with the situation with the early pregnancies, you talked about like multi-sectoral efforts. So I'm curious to see what efforts is the health secretariat taking in conjunction with other secretariats in terms of ameliorating housing and like waste management that affect the reemergence of diseases such as like yellow fever in Latin America. Thank you.
Thank you, Jimena. Mr. Undersecretary, why don't I allow you to respond to those questions and comments and things that you heard on the panel, and then we'll open up the discussion with the panel. Does that sound good? I'm glad I'm the boss, I know. It does sound good, doesn't it? It sounds fabulous.
No, it does not. Well, first, the philanthropy issue, I think it's an issue for Mexico. I mean, we don't have that, I don't have an answer for your direct question, but I know it's an issue. We discussed that. We were talking before we started the panel that there's not a lot of philanthropy in Mexico. That's the truth. And I don't know how we should really approach the issue in Mexico, because there's how can I tell you? What I perceive is that there's not enough incentives in Mexico for philanthropy to be really something that's attractive for people that are on the philanthropy issues. I mean, it's not only philanthropy, pure philanthropy, because it has also benefits for the people that put the money on that. And I think that what we're missing in Mexico is really a good and sound policy for philanthropy to increase in Mexico. So I really don't find another answer at this point. It's not a policy. At least I don't know of a policy, a governmental policy in Mexico to make philanthropy something that could be helpful to deal with these and other problems in which philanthropy has been very helpful in other scenarios, like in the U.S. And I didn't have the figure that it's going down in the border, but it's worrisome, because it sometimes is the only way to deal with some of the issues, not only in health, but in many other problems that we have to face. So I don't have a direct answer, but I think it should be through incentives for philanthropic venues and things that could be done in that area. Health priority. I think that health is not a priority because it's not perceived as a problem. Very, very straightforward. I mean, the society, if it was perceived as a problem, they would be demonstrating, and they're not demonstrating. In fact, it's interesting because I cannot understand when you talk on a one-to-one basis, and you ask people, what do you think about the service that was provided to you? No, I waited a long time and it's terrible, blah, 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 blah. But when you do the surveys, and one of the questions, the usual question is, what's your perception about the service that you get from the public sector? Good, very good, bad, very bad. It's always good or very good. I don't know what happens, but it's a matter of perception, social perception, and that of course precludes the subject to be a high priority, because it's not a social demand. And on the line of what Amy said, I would really love to have diabetes patients demonstrating in front of the Ministry of Health, because that way we will have more budget.
Yeah.
Oh, really? I mean,
Giving me a new strategy.
Yeah.
I don't know. No, because you can see that, for example, with the HIV patients. You know, we have a national council on HIV, and currently it's not please don't misunderstand me, okay? But it's not a priority it used to be when it started. Currently we have all the medication is covered by the catastrophic funds. So everybody that gets to the system has it's covered. So people don't die from HIV if they take their medication. They actually don't die. They die from something else, but not from HIV. I mean, it's not as when it started, but we don't have a national center for diabetes, which is really killing people. And I don't know how much civil society has been a key stakeholder, which I think it has, into prioritizing issues in health and health as a whole. So that's my understanding. And let me tell you that it's not being candid. All this information is public. I just put it together and show it to you. So I'm not saying anything that is not available anywhere in our pages or somewhere else. The things that are not available, I will not share with you. No, that's just kidding. And vector-borne diseases, of course, we work with the municipalities. And basically, those are the ones that are responsible for doing the things that you say. In fact, there's a network for health. It's a ¿cómo se diría? Red de Municipios por la Salud. It's municipality network for health. And basically, those are the authorities because they are the ones that are responsible for having water, for picking up the garbage, for doing all the things that you were saying. And we work a lot with them. It's not easy because there's a heterogeneity, a big heterogeneity in the country. So I can say that we have 32 countries within the country, and within each of these 32 states, we have very important differences. And it also depends on who's the municipal president. If you have people with a good educational background, and you have those, because I know them. For example, you sometimes get physicians which I ask them, what are you doing at this position? You should be treating your patients, but well, blah, blah, blah. But they understand much better and are much more helpful than if you have somebody that comes from another background. But actually we work, and it's an issue, you're completely right. It's not only the urbanization process, it's the climate change, and there are many things that you have to deal with. There are on the scope. They are not easy subjects, and you have to put in the train many people from other sectors. But I'm going to say something that's going to sound very strong, especially because I know there are lots of economists here. Am I right? Yeah. Yes. Okay. They're not trained to have the social sensitivity. There are areas of knowledge that don't have the social sensitivity. And it's okay. I mean, it's just a matter of the background. And I have many discussions with economists, many, because I understand it's all cost benefit, and as somebody that I really respect a lot, once said to one senior economist of health in Mexico, when are you going to put in your equation people and the health people? I'll leave it like that.
Thank you very much. There's another question over here, which I'll be delighted to take right now, another one right here. One here, that will take another round of 3, and then I've got a series of questions or issues that I'd like to put to the panel. Okay, so please, over there.
Sorry, where?
Right there. There, thanks.
Thank you. Hi, my name is Rodrigo, and I'm an intern at the Albright Stonebridge Group. Thank you very much for your presentation, Mr. Morales. My question is general, but it has 2 sub-questions, and I wanted to ask you about continuity. Right now in Mexico with the election... Continuidad. First, because of the presidential elections. So right now, for example, with the energy reform, there's a lot of talk about whether the new reforms are going to be able to survive the elections. So I wanted to ask you about that same question, but in regards to the healthcare system and any kind of healthcare reform that is ongoing. And second, is specifically in regards to issues that, let's say, for example, you were talking about teen pregnancy, that can be more political at a political level, for example, with contraceptives, right? So in those states where, for example, now you have PAN that have won around 10 to 12 states, the governorships, I want to understand better, if you could help me understand better the role or the kind of interaction that exists at the state level with the federal level when it comes to issues that are more political, and how that affects budgeting, how that affects priorities at the state level and the municipal level, which you were saying is where a lot of the magic happens. So kind of the general theme is continuity, but in relations to presidential elections and local politics. Thank you.
Thank you. Thank you, Jimena.
Thank you. Ruben Barrera with the Mexican News Agency, Notimex. Thanks for your presentation, Dr. Curry. And now I would like to go to the budget issue. It caught my attention when you say that the budget for the health sector in Mexico has been increased in more than 600% since 2000, I think. And also you mentioned the possibility that you will have a reduction next year due to the, several factors, especially the decrease in oil and obviously revenues. Certainly this is not the first crisis that the Mexican government has been facing. There has been a previous adjustment in other budgets. So the question basically is, how worried is the Secretaría de Salud about the potential cut in the budget for the next year? Or, I mean, you are not worried at all because maybe now the Mexican government or the central government realized the importance to have a well-funded health sector in Mexico, given the challenge that you mentioned a couple of minutes ago.
Thank you, Ruben. You can just pass the microphone across the table. There you go. Thank you.
So there's a webcast available for those who were not able to attend. So I'm taking one question of a viewer. And his name is Mario Rosas Montes. He's a student, a medicine student in Mexico, and he was wondering what is the position of institutions such as the IMSS and ISTE in the face of the new model of open government, when we know that the data and the form of internal governance of the IMSS is close.
Thank you. Now, our other panelists, please feel free to jump in if you have responses or if you disagree strongly with the Undersecretary on any issues.
I was asking if this was my PhD dissertation. Well, continuity. If I had the answer, I wouldn't be here. The honest, to be very honest, I think that one of the things that has been quite continuous in Mexico is public health policy. It has been there basically since early 1980s, and it has been continuous regardless of PAN or PRI. In fact, during the PAN administration, we got the emergency pill into the basic chart in the PAN administration. It was not easy, but it was there. Because I think that one of the major challenges that we're facing is that they are politicizing health, which should not be. We're convinced that the people that are really brought up in public health, we think that colors or parties or whatever are regardless. I mean, one of the few values that's universal is health, regardless of what you think or what you feel or whatever. Of course, there are things that you have to face that are true. For example, in family planning, of course, there's ways people that think different. And we have to be very open. What we are saying and trying to convey the message to the people is you need to be informed. And at the end of the day, you take your own decision. Something that we're also conveying is that I cannot do for your health what you don't do for your health. I have to, as a system, as a government, we have to give all the facilities and all the information that is needed for people to make a well-informed decision, but I cannot change the way people think, and I have to respect that. So that's something that's been there, and I can tell you, for example, one of the, and I didn't mention it, but vaccination is one of the main policies in Mexico, and it has been there for more than 30 years, and we have good results regardless of who has been in office. Now, there's a challenge at the state level, yes. There's a challenge even more at the local level, yes. And then at those levels, we don't necessarily have the control that we would like to have. In fact, on your question about, are you worried about budget, I can answer very honestly, we're worried enough. But what I mean is that actually we know that there's a lot of expenses that are not necessarily being done properly. So we think that reallocating even the funds could deal with the problems. But there are things that you cannot change. For example, if they take money from vaccines, if one vaccine costs $1 and you have to buy 100 and you get $100, you will buy the 100 vaccines. But if you get $90, you will be short 10 vaccines. But there are other things that can be surmounted if you reorganize or make a more efficient use of the money. And I can tell you that there have been a couple of changes in the social system of Seguro Popular, which is el Sistema Nacional de Protección Social en Salud, which is the correct name of Seguro. Seguro Popular is the brand name, but actually it's not the proper name. And what happened is that you put all the money in the states without control of how they spend it. Now that has changed a little bit. That there has been a change in the law. There's a new change in the law in which they will be penal, yes?
Penalties, you'll penalize.
Penal, no, responsabilidad penal.
Criminal.
Legal, criminal responsibility, liability, if they don't spend as they should, which was not there in the law. Now, we have very, very nice laws in Mexico. Now the thing is to enforce them. But again, it's now in the law which was not there. So I think that we are worried. Yes, we're worried, but we have still to wait because, you know, the House and many of the parties have said that they will do things not to have such a big cut in health because they are conscious that the first thing that you need is to have health to do the other things. So that's something that's there. And I'm sorry for our colleague from the student that asked me about IMSS. It's a difficult question because this is, you know, IMSS is a very monolithic, I would say, institution. It's difficult to make changes in IMSS, but now I think that there's, and it was mentioned here, Mikel Arriola has a very modern view of what has to be done, but he has to deal with many things within the institution to make some changes in order to make it a more movable and more capable of responding to the challenges that we're facing. And something that was mentioned here, I think you mentioned, Andrew, it's a issue that IMSS and ISTE are not only healthcare providers. And I don't know what's going to happen at the end of the day, but and you mentioned something that we're under a reform. We're not under a reform. That's the issue. We have to make, I don't know if it's going to be called reform or whatever, but we need changes in the system. Yes, we do. And everybody's conscious of that. Now, what changes? It depends on who you see, because when you see this document, may I grab your document here? This one. Which, by the way, I don't agree with it. And I was very clear when they presented this in Mexico. There are things I agree with, but there are some that I don't agree with them. And of course, these documents give you recommendations. They tell you what to do, but they don't tell you how to do it. It's very nice to tell people, you should do this, but how? I mean, it's very easy to tell you what to do, but how do you do it in the real setting? Because theoretically, everything is very nice. Mm-hmm. But you have to go to the ground to deal with the problems of the people. That's why I'm telling you that it's very important to have in the equation the people, and the people's health, and the people's feelings, and the people's problems, and the people's, which is very romantic, I might say, but if you forget that, that's what's happening. And that's where we are, and not in health in general. That's why we have so many problems everywhere, because we're forgetting that people should be in the center, from my point of view.
Could
Yes,
I
Amy, please.
jump in, just related to the question about how do we help raise the profile of health? I mean, I do think the private sector has a big role there in terms of putting this on the agenda and trying to explain why health is important. I think as different segments of the private sector, sometimes we come in with our own specific messages instead of having that bigger macro message. And I think if we work on that bigger macro message, why health is important for the economy, we're going to do a lot better. And one key point in terms of how to make Mexicans interested in their own health is also the fact that right now the situation is very inequitable in Mexico. I mean, speaking of innovative pharmaceuticals or treatments, if you have access to, or you can pay out of pocket or you have private healthcare insurance, you can have access to the most innovative medicines on the market. If you're being served by the public sector, you probably cannot. And that's simply, there are many factors involved in that, but whether people are aware of that or not is a question. But it's certainly something that I think has to be discussed honestly in terms of, it does very much matter what your income bracket is in terms of what kind of service you provide. So if we're going back to the human element, doesn't everyone deserve the same type of service? In an ideal world, yes. Is it easy to achieve? No. Is there a long way to go? Yes, again, and I would agree with the Undersecretary that this is probably going to require a pretty massive institutional change, and sometimes it's difficult because it's harder to change a system that's already in place than to almost like tear down the building and reconstruct. So, I think it's going to take years to kind of work through this, but those are some ideas on how to approach it, perhaps.
One comment. We have all talked about what the problems that we're facing, but let me just share with you some things that are there, and there are, I don't know if we have to discuss those, but the indicators that are related to health and the advances in health. We're advancing, so we have lots of problems, yes, but we're advancing infant mortality, life expectancy. I know that they will say, well, it's the country that increased the least, but we have increased life expectancy. And infant mortality has gone down, maternal mortality has gone down, breastfeeding, exclusive breastfeeding has gone up. We're not where we want, but we have gone up. So there are some indicators of health strictly related to health, that are not as bad as so I think we should analyze a little bit more what has been done properly, because the indicators are there. You can go, those are not things that I can imagine. For example, we just eliminated onchocercosis from Mexico. We're going to eliminate trachoma, and we're going to be the first country in the world to eliminate trachoma from the country. So there are things that we're doing properly that have results. Of course, we would like to have more results, yes, but we duplicated exclusive breastfeeding in 4 years. I'm not saying that we're on the level that we want, but we were on 14%. Now we're on 30%. And that was measured by UNICEF, not by us, which is an independent, so there's no bias, no whatever. And I asked the guys that measured that if they really were comparable the way they were the exact same questions. So they're comparable. So just to say that, yes, we have a lot of problems, yes, we have a lot of challenges, but we're moving forward. And there are some indicators completely related to health, and others like infant mortality that are not only related to health. Infant mortality is one of the most sensitive indicators that has to deal with social development.
I think that's a great point, and I think that gets lost sometimes. The one thing I would just add very quickly is I think you can also look at the benefits to Mexico by investing more and more smartly. And I think that goes to kind of the U.S. Chamber initiative that Catherine was describing. So I agree with you. There's a lot of things that are going well, but there's also a whole added topic there on the additional benefits that could come by looking at your productivity.
Thank you. I promised that I would make this question, and my Apple Watch has just tapped me and told me it's time to stand up, so we must be getting to the end of the panel. I'm actually interested in hearing if you do have any opinions on what wearable devices do for public health. I know that it's a permanent bane for me. It's like, oh God, I haven't met my goals yet. I've got to go and ride my bike or run up and down the stairs or do something, and oh God, I just ate a chocolate bar. I've got to go and do a little bit more. But I wonder if the role of technology in general is something that I'm interested in here, and I'd be interested in responses from the panel. But the question that I promised I would put out here is, what are the issues that we can meaningfully and realistically place on a bilateral agenda between Mexico and the United States? Issues that we can talk about beyond the collaboration that we've seen on pandemics, infectious diseases. We're lucky enough to have with us Marta Caballero, who is the Director for Bilateral and Regional Cooperation. As a former student of mine, I have to say that she's obviously a genius. So she is going to be sitting there waiting for feedback from the panel. I wonder if I could ask you, perhaps beginning with you, Catherine, ideas that you have on one of those two issues, particularly the second.
Actually, I was going to take the first.
Do it.
Well, and I would just like to follow up on the comment about, you know, the approach that maybe economists take in presenting their analysis of an economy to policymakers. And we've been a little deliberately in our lane as an employer organization, talking about return on investment, in part because we think that enables you to talk to your colleagues in the Ministry of Finance to make a case for greater spending, and the result of which is, you know, benefits to our employees and consumers and benefits to your citizens. And my organization is not known for being a Care Bear, and if I put, you know, a nice narrative of a person up there, I think this is our lane, and this is what we thought would benefit you in your advocacy the most. I'll pick up the technology point, and firstly on the wearable, I think from a government's perspective, that's a great burden shift for a government to have personal responsibility on health. I think is important for all economies around the world, particularly when you're dealing with diabetes and obesity, and technology adoption by consumers is rapidly increasing and should be embraced and have those markets brought, have those products brought to market quickly. And then obviously the benefit to governments of technology in the data analysis, in finding efficiencies, like the Undersecretary said, if there's no more budget to be had, then making the budget work harder. Data really enables that, and the analysis that Mexico's been doing with their system, I think hopefully gives us opportunities to find a better spend within what's available.
Sure, thank you. Andrew.
Thanks. So, I'll try more to focus on the question of the bilateral issues or the opportunities to collaborate, and maybe I would just start by saying I think in fact our system, the U.S. people generally say, oh, the U.S. system and the Mexican system are completely different, so there's nothing to compare, there's no way to collaborate. And I would argue that both systems are actually converging a little bit. We don't have the same system. I don't mean to imply that we will soon have the same system, but we have the Affordable Care Act, which is a goal which drives toward universal coverage, which Mexico has. As I alluded to, I think there's an increasing focus in Mexico on finding, if you will, out-of-network care, that private sector care. So there is convergence, and so I think one thing that could be discussed more on a policymaker to policymaker level is exactly what policies do you need and what do you implement to facilitate public-private partnerships, to find efficiencies in your system. I think there could be some really good best practice sharing. I alluded to university or academic institution collaborating. And maybe the last thing I'd throw out is, specifically in the border region, I think there's huge opportunities for taking advantage of the differences in the two systems, whether it's there's a company in Southern California that offers medical care to non-Americans, that is Mexicans living in California, and they go across the border to Mexico and get health care at a lower cost. They can't offer that service to American citizens. In fact, the owner explained that they were supposed to ask if people were Mexican, but they didn't want to get into trouble with sort of questions of profiling. And so I think the understanding is, as long as the applicant is willing to say they have Mexican roots of some sort, they don't ask any more questions. But I think there are lots of opportunities, both on the micro level of right across the border and then broader policy areas that could be explored.
Thank you. Amy, as an American and a Mexican, how do you feel about this?
Yeah, I mean, I would coincide with the idea. I think we should be ambitious. I mean, right now, politically, it's hard to think very ambitiously given the way that kind of the bilateral relationship has been so attacked during this election. However, I think we need to push for greater ambition, and I think, frankly, there should be a move towards being able to have to use Medicare in Mexico eventually, to try to figure out how we could have mutual recognition of the health care in both countries. I mean, it makes sense with the aging U.S. population that there could be a real advantage to having a lot of retirees get their health care in Mexico. And it's something that has been discussed a lot, but that it just hasn't, really gotten the traction. But it does seem a logical, if not ambitious, thing to work towards.
Especially with 1 million United States citizens living in Mexico
Yeah.
at this point in time. Mr. Undersecretary, your final words.
Thank you. Not really. I think I appreciate the opportunity. We could continue talking for hours and hours, but I really appreciate the opportunity.
Thank you so much for being with us. We really appreciate your presence, your wonderful presentation. That graphic that you showed of the importance of primary care versus the resources being dedicated to it, I think has stuck in many people's minds here today. It's quite startling, I think, and good to focus on. Ladies and gentlemen, thank you very much for being with us today. Please watch this space. We will be building our public health programming here at the Mexico Institute. Our next programming that's coming up here, though, will actually focus more on North America issues. We're having a stakeholder outreach dialogue here on Thursday, looking at questions of economic competitiveness. That's a private closed meeting, but we will actually be presenting the report from those meetings to the general public, and we will be inviting comment through our website. So